Okay, everybody, welcome back. This will be your video lecture, Chapter 45, Geriatrics. I hope everybody is doing good. And let me introduce the chapter to you. So, the U.S. population age 65 years and older increasing, and it expects to continue to increase because medicine is just so good nowadays, and that technology's come a long ways. Life-saving techniques and operations and procedures have come such a long way. Common reason older adults require EMS, well, cardiac and respiratory problems, neurological problems, injuries from falls, and non-specific complaints. So let's look at the AEMT here. Life expectancy, 77.8 years. What's some of the influencing factors on that? Well, gender, genetics, environment, and lifestyle. Age-related decline of body system function decreases the ability to maintain the homeostasis due to anatomical and physiological changes. Neurological system, brain changes with the age, right? Clinical depression, altered mental status is common, and loss of proprioception. Cardiovascular system, well, hypertension is common, and changes in heart rate and rhythm. Gastrointestinal system, constipation is common. The smooth muscles in those intestines just don't move that food as good as it used to. Doesn't move it around as much. Deterioration of structures in mouth, general decline in the efficiency of the liver. So that's why we got to be careful why we're giving medications, but especially those primary care physicians who are writing prescriptions to the geriatric patient, because the liver filters these meds so much differently than that of an adult patient. Impaired swallowing and malnutrition, deterioration of that small intestine. Again, another reason why we're constipated. Musculoskeletal system, osteoporosis and osteoarthritis are common. When we look at the respiratory system, the cough power diminishes. Also, the brain stops sending out those messages to cough as much. My brain has no problem with that right now, just to reassure y'all. Been coughing my head off now for about 4 weeks. Increased tendency for infection, and less air and less exchange of gases. The renal system, well, drug toxicity problems are common. Why? Because the renal system's not quite as efficient of getting that urine out, and a general decline in efficiency. The skin, well, all of these organ systems when you get older just go to hell, don't they? The skin, it perspires less, tears more easily, heals slowly. And the immune system, fever is often absent, which is very interesting, but it's so true. And lessened ability to fight disease. The immune system's like, I've been out there whipping ass and taking names now for a long time, and now something's come along, and I just, I know I can go out there and win. I just don't feel like going out there and being aggressive as I usually am. There'll be changes in vision, age-related hearing loss. Sometimes it's not hearing loss. Sometimes it just takes a minute to process the words from the sender to the receiver, right? And sometimes that's blamed on hearing loss, but it's not really hearing loss. Sometimes we just have to be patient with this geriatric age group and let them process what you're saying. Weight control is more difficult. We start seeing a lot of type 2 diabetics inside this age group. And then we have an increase in incident of cancer. We have menopause in women in their late 40s to early 50s, and that can increase cardiovascular disease. Their skin is paler. loss of elasticity of the connective tissue, and the muscle mass decreases, skeletal muscle weakens. This is a chart, and it lists body systems, changes, and possible consequences. And I'll let you kind of go through the chart and make yourself familiar with this chart. It's chart 45-1. So let's look at this patient here. It has some age-related changes in the body system. And not going to spend a lot of time on this because this is what we discovered. But you can take a look at that. It's 45-1. So when we're looking at the AEMT, fractures occur with minimal force. Okay, so it doesn't take a lot. This is where the ground level fall, and the adult patient is really no big deal. You can get up and walk around, usually after a syncopal episode. Not in the geriatric age group. If they suffer a syncopal episode, they probably fractured their hip on the way down. Their blood vessels thicken. You have increased systemic vascular resistance, right? So think about that. If you have an increase in systemic vascular resistance, this is where what your hypertension comes from. That's where that disease process comes from in the geriatric patient. Those vessels become to where they get stuck in a constricted state and they don't dilate as easily as they used to. Decreased organ perfusion and an increased workload on the heart. Right? Anemia and decreases response to infection. All that can be dangerous. They have a decline in the respiratory system. The chest wall becomes less compliant. They have a decreased sense of taste and smell. And that leads to what? Malnutrition. If you don't like what you eat, if it all tastes the same or doesn't taste at all, then that leads to malnutrition, weight loss, and then vitamin deficiencies. They produce less insulin, right? Or the insulin they're producing is not as potent as it used to be, and this leads to diabetes. Liver function decreases, inefficient elimination from the body. We talked about how the liver, right, how its function decreases a second ago. A decreased sensory function, reaction time, and proprioception. Right, so you touch a hot stove. Well, I'll move my hand pretty quick, but geriatrics will not. It takes a minute for that message to get sent to the brain that, hey, this is bad. Vascular disease and inflammatory processes can lead to dementia, and pain perception decreases. So the psychosocial aspect of aging, well, that's a big deal. 9.7% at the age of 65 are living below the poverty line. 13% of the 85-year-olds are. We have a lack of adequate income and social support that can result in potentially dangerous situations. Well, one dangerous situation is if they don't have the money to get their prescriptions filled, they're not going to get them filled. Loss of function, they lose their independence. They lose their companionship. Their friends are dying off, folks. And when Bill dies, I don't know what I'm going to do. I won't have anybody to call. So, and then there's the financial burden that becomes with it. Then we have elder abuse, right? So once the family say, we can't take care of Pops anymore. He's pissing all over himself and we can't clean him. So let's put him in a group home somewhere. Well, that's going to open that up for possible risk of elder abuse, getting their money stolen from these folks or not getting cleaned up. They're just taking their money and running to the bank with it. Kind of sad getting older. kind of sad. Financial and physical dependence on others increase. So you're very vulnerable at this age group. And so then we have an increase in depression. Why? Because I pretty much explained it, but seriously though, like if you get to the point to where you go to a family reunion and you can't participate in the conversation because it takes me a minute to process the sender's information, and by the time I'm ready to talk, you guys have already moved on to a different conversation. And so these folks become depressed because of that. They don't fit in anymore. People won't wait for the old folks to talk. They just want to go so fast and not give Pops time to talk. The majority of the elderly live independently with minimum assistance or with family members. So you're going to look for all of this when you do your scene size up, right? You want to look to see if there's a chance the patient's being abused. You want to look to see if there's a chance that the patient maybe they have a cognitive disorder. They're not taking their meds. They're not able to clean their house. They're not able to make their own meals. All of that is things that you need to include in your general impression or scene size up. And you have a responsibility to report that to DFACS if you're finding that. So communicate directly with the patient. Even if you're lucky enough to where they have a few family members and they called 911. I have a mother that's 94 years old, and she gets so pissed off that when my sister takes her to the doctor, that they'll carry on the sidebar conversation, and she will very much remind them and that physician that she is the patient, not her daughter, and that doctor will communicate with her, and he will slow down, and he will answer her questions. And it's pretty funny, but she is just like that. And so it's okay to have those sidebar conversations, but you need to make time and you have to be patient. How are you feeling today? It's that awkward 4-second pause that you have to give them in order to get that answer. And it's funny because if you start doing that, you'll hear the family go, "Oh, well, Mom's having a really good day today. She's normally not able to answer these questions." She's always able to answer those questions. The family doesn't give them time to answer those questions. They're not patient enough. And I guarantee you, try it out and see if it works. Also, I didn't mean to skip over this. Determine your patient's normal baseline condition. That's super important when you're taking the patient to the hospital. You need to be able to explain to the hospital, if at all possible, this is the patient's baseline. Or the patient's baseline is normally, the patient's normally confused to person and place. They usually know what time it is, but today they don't. Today they don't even know what time it is. Today they're completely confused. The primary assessment is the same. We're not even going to... these are common complaints in the elderly and their significance. So abdominal pain or discomfort. And then, so we got to be careful, right? Because let's say we have a patient who's 75 years old who has a history of hypertension, and they've had that hypertension since they were in their 50s, 40s, and now they're complaining of abdominal pain. Well, we got to worry about that aortic dissection in this patient, right? Because this patient's 75 years old, they've had a history of hypertension. These vessels have been really worked hard. And there's a good chance that we have an aortic dissection in this age group. So we have to be worried about that. Everything else, too, that goes along with the age group, like gastroenteritis, GI bleeds, bowel a bowel obstruction. Remember, the small bowel is not moving that food to the large intestine quick enough, and it all can back up. If you go through this table 45-3, it's a pretty decent table. It will give you things to consider that are in the geriatric age group, like COPD. Normally we don't see too many kids that are 20 years old with COPD, right? That definitely is a geriatric age group disease. Heart failure, lung cancer, all of that. So just go through this. Make sure you're familiar with these disease processes. All right, so medical problems and trauma that can overlap in the elderly patient, right? So these patients can fall down some stairs, but it was secondary to their hypoglycemia, right? So we end up with a trauma patient that could be a medical. Or my mother broke her hip. She had having an MI, and she had a syncopal episode from the cause of the MI, and then she broke her hip. So the hospital was dealing with her having an acute MI, but after they fixed that, they had to fix the hip, right? So those are some of the things that they're talking about here. They use this term called confabulation. The patient unknowingly fills in gaps in memory with information that seems to fit, but it's not exactly true information. So that's what you got to remember, like cognitive disorder with this age group, right? They'll swear to you that they took their medicine, but it's obvious by the count in their medicine that they didn't take the medicine. That's why the spouse, family members, caretakers can be a really good source of information. Elderly patients have difficulty staying warm, and they may wear several layers of clothing. Do not cut the clothing unless it's completely necessary, because they'll get angry about that. Elderly patients may have a limited range of motion. All right, some movement's painful just because it is, right? Wait till you get older. Your shoulders start hurting you because you pulled so much rock over the years, right? Your shoulders start hurting. Your back starts hurting. It's just part of this, part of your job sec that you've chosen. A wonderful job. Love it. But there's some pain that goes along with it as you get older. So that's something you got to add into it. If the patient had a fall and maybe you're checking range of motion, it's no trauma to the arm. It's just because it just is. It hurts. Some elderly patients have a decreased sensitivity to pain and may not complain of a level of pain expected. And so what we have to do is we have to worry about these patients when it comes to MIs, cardiac-related chest pain. They may not have severe pain as they get older. That's a picture of a patient with cataracts. Kyphosis, right? So remember, that's that bad spine angulation of the spine. If you ever have to immobilize somebody this old, God, please use. That's why I don't. Is because it's ridiculous. You're not going to be able to. You're going to have to end up using so much padding that you're not going to be able to put them on a backboard. Because the backboard loses its purpose after you've got so much padding underneath it. In this case, they're using it for a C-collar. I get it. If you need to put a C-collar on, that's definitely the way you want to do it. Always consider the effects of aging, the drug side effects and interactions. That's because they're going to take a lot of meds. Right. So what is aging and what is the side effect of the drugs that they're taking? Just kind of going through here, picking out the stuff that's important. So let's talk about some of the causes of dyspnea and hypoxia for the geriatric patient. Anemia. So a lack of red blood cells, specifically hemoglobin. Asthma, COPD, heart failure, pulmonary edema, lung cancer, myocardial infarctions, pneumonias, pneumothorax, pulmonary embolisms. So pneumonia is a common cause of death in the elderly. Fever, chills, pleuritic chest pain, tachypnea, dyspnea, a productive cough, altered mental status. Now, a lot for us to do here to support, treat them with some O2 to keep their SATs above 94%. And if they're dehydrated, we can give them some fluid. We should suspect a pulmonary embolism with sudden onset of dyspnea. Massive pulmonary embolisms can quickly lead to hypoxia and cardiac arrest. We want to treat that patient for hypoxia and hypotension and transport without delay for a really quick CT scan. So pulmonary edema is often a result of left-sided heart failure. Left-sided heart failure is a result of probably an old MI. Respiratory failure, respiratory arrest, cardiac arrest can ensure rapidly. We're going to use CPAP. They're probably going to be super hypertensive. So we're going to do what? We're going to give some nitro. And I would use CPAP before I ever thought about trying to use a BVM, unless they lose the status of maintaining their own airway. That's funny. Syncope is a common and elderly with cardiovascular problems. And it is, right? This is just gave you an example of that. Also, when you're dealing with acute coronary syndromes, dysrhythmias, which can lead to syncope. And so, silent myocardial infarctions, again, part of the geriatric disease process. All three of these, just remember, with those syncopal episodes, if they go down, you got to be able to, you're going to be dealing with both probably fractured something and a medical problem. Acute myocardial infarction, epigastric or abdominal pain or discomfort instead of what? Instead of that classic mid-sternal chest pain that radiates to the left arm. And you really got to think about these in females versus males. But once you get to that geriatric state, both male and female can present like this. Again, it says consider aortic aneurysm or dissection with abdominal pain, back pain, unexplained shock, or loss of pulses, sensation, or function, particular lower extremities. So they had a guy come in the other day to the ER. His complaint was bilateral hip pain. Hips were killing him. And I was working triage. And I said, okay, let's get some vital signs on you. Slapped a blood pressure on him, 84/50. And I immediately thought of a aortic aneurysm. Why? Because he had no history of trauma. He was having lower pelvic and back pain, and he was hypotensive. Those are the ones you're looking for, an unexplained shock. And so we need to think then aortic aneurysm. Neurological disorders. So yeah, geriatrics have strokes, right? They have strokes, they have TIAs, seizures, and dementia. All right, so we're going to do that Cincinnati pre-hospital stroke screening. We're going to transport to a stroke center as quickly as possible. When it comes to dementia, sometimes it's progressive. It's usually irreversible and can lead to Alzheimer's disease. We've talked about this. Let's talk about we kind of talked about endocrine disorders. Remember type 1, type 2 diabetics. At this age group, type 1 is already going to be identified when they were young, much younger. Now they're going to enter the stage of being in that realm for type 2 diabetes. And that's, again, usually due to their insulin either not enough being produced, or what's being produced is not as potent, right? It's not as strong as it used to be. And so what affects that? Well, major surgeries, infections, or illnesses such as an MI can increase the risk of that diabetic patient going into DKA. Even a type 2 diabetic, as you get older, they can slide into DKAs with major illnesses. So they just been released from the hospital. You get out there to their house. You're assessing them. They have a sugar of like 415. They have Kussmaul type respirations. They're probably DKA. And we're going to have to go back to the hospital. We've already talked about these infectious diseases. Let's talk about Foley catheters for a second, or indwelling catheters. This is a super, super high risk for a urinary tract infection that can lead to something called urosepsis. So if you get out there and you're assessing a patient with an altered mental status and they have a Foley, remember, fever doesn't always go with sepsis in these older folks. Look, if they may be tachycardic, that's enough to assume that they have urosepsis, and let's get them back to the hospital. So anemia in geriatric patients, it can happen. A lot of times, again, the anemic patient complains a lot of times of weak, fatigue, shortness of breath, or just lack of just a failure to thrive. A lot of times it's because they don't have a lot of hemoglobin, and hemoglobin is transporting oxygen to those organs. So basically, they're what? They're hypoxic, and they're going to need a blood transfusion. All right, guys, that's it. That's pretty much the highlights of this chapter. Read over it, look over those charts, and I will post this for you and look forward to seeing you in class.